Now, pivoting on to our next panel titled Value-Based Healthcare Delivery, Transforming Payment Models to Prioritize Quality and Outcomes. Let's dive into how the healthcare system can shift from volume-based care to patient-centered results. For decades, healthcare has been built on the fee-for-service model, rewarding volume rather than value. But what if the hospitals and providers were incentivized based on patient outcomes instead? Would it lead to better care, lower costs, and a healthier population? In this session, we are taking a look at the shift towards patient-centered care, its challenges, and whether alternative payment models can truly improve healthcare efficiency. Is this the future of medicine, or are we not ready for the change? Let's answer this question by calling on the stage our moderator for the next session, Dr. Tandria Callens, the CEO and principal of the Language and Literacy Academy for Learning, Inc., and the rest of our panelists. Welcome them with a big round of applause.
Good morning. It's so good to see each and every one of you here today. I'm Dr. Callens, and I am a speech-language pathologist. I'm certified as an ADHD coach, a clinical specialist for autism spectrum disorders, and a certified youth mental health specialist. We're going to get started with our panel discussion today. And we are going to start off with introductions. I'm actually going to have a seat.
Awesome. Hello.
And we are going to start off with our first panelist, Dr. Abhishek Kumar.
Great. So my name is Abhishek. I'm the Director for IT Solutions at Iconma. I'm very, very excited to be part of this discussion on value-based care and its transformative potential. I mean, as we all know, the traditional fee-for-service model often, promotes volume over quality, which leads to escalating cost, fragmented care. So the value-based care offers a very compelling alternative, where it focuses on patient outcomes and reward providers on providing efficient, high-quality care. And in the heart of this entire transformation lies the power of data and analytics. And I'm looking forward for a very productive discussion on this today with my fellow panel members and with the great audience who have joined here. So looking forward for it. Thank you so much.
Good morning. My name is Dr. Aditoro Oriaifo, and I currently serve as the Chief Pharmacy Officer for Total Healthcare. So Total Healthcare is a federally qualified health center that's located in Baltimore, Maryland. We care for about 30,000 lives annually, providing comprehensive healthcare services, pharmacy services, dental services, behavioral health, and we also provide specialty services in infectious diseases and podiatry. Again, today, thank you. I am so excited to be here to have the opportunity to be a part of this very important discussion about value-based health, value-based care. But again, for me, it's more from the perspective of the role of the pharmacist, right, as a healthcare member. Again, as a healthcare leader, a pharmacy advocate, I've had the opportunity to work across clinical, operational, and even the public health space. And I see the opportunity that pharmacists can play. I see the potential for pharmacists to participate in the value-based care and how they can help drive the positive healthcare outcomes, which is the whole purpose of value-based care. So again, I'm looking forward to having a very interesting conversation today. Thank you so much.
Thank you.
Good morning, everybody. Fantastic to be here in Las Vegas. Just finally getting over my jet lag. I got in on Monday afternoon, and I'm finally over it, but I'm going to be back on a red-eye tonight. My name is Mustali Dohadwala. I'm a clinical invasive cardiologist. I have my own practice a little north of Boston, about 14, 15 miles north of Boston, Massachusetts. I cover over 3,000 lives. I've been able to successfully run a solo practice for almost 15 years now, with a mission, a model to provide exceptional care to each and every one of my patients, my members, without exception. And I feel so blessed, humbled, honored to be part of this discussion, because I think we're at a very important crossroads right now in healthcare. And I think that right now we're really going to be addressing a seismic, I would say, philosophical change in the way the patient-healthcare provider relationship will be, if it hasn't already become. I truly believe that there's going to be a tremendous change in this particular relationship. And I think this value-based financial incentivization, I think most would agree that will relieve I would argue all healthcare systems, groups, solo practitioners such as myself, from inherently over-treating, right?
Right.
Or under-treating.
Yes.
So I'm excited to be here. Thank you.
Great.
Thank you, panel, for being here. Now, what I would like to do, in order for this conversation to be meaningful to you, let's start off with questions from the audience, because we want to make sure we address your concerns or your questions, because we're involved in our fields every day and we can talk about this all the time. But are there any specific questions or concerns from the audience that we can address ahead of time before we delve into this deep conversation?
Exactly, because we can keep speaking the whole day.
Okay, so let's go ahead and get started. I think it is important for us to all have a foundational knowledge and understanding of value-based care. I don't want to assume that you all understand or know what that exactly means. So if Dr. Kumar, if you can go ahead and get started and just give us a foundational definition in your line of work of what value-based care is.
Absolutely, absolutely. So actually there are, thanks a lot, Andrea, for that. And there are 5 key talking points which I like to put across, more like a food for thought for all of us here. The first one is, as you rightly asked, Andrea, defining value in the value-based care. Okay, that's the first point. And I'll get deeper into that one. The second one is data-driven foundation for the value-based care. Okay, that's the second key point. AI as a catalyst to VBC, value-based care. Okay, that's the third point. Then overcoming barriers to data-driven VBC, because that's another very important point what we have to ensure. Okay, that everything is great, but if we are not able to overcome barriers, everything is a loss. And the last but not the least, what is the future of VBC using data and AI? These are the 5 key talking points that I would like to start with, okay, more like a food for thought, and we'll keep delving deeper into those. But now coming back to what Tandria just said, defining value in value-based care. Now think about it. In value-based care, who are the 3 primary key stakeholders, okay? They are, everybody, you all can guess, right? It's patient or the members, or like all of us. It's the provider, and the payer, insurance companies. These are the 3 key or primary stakeholders into that, right? Now, a value can be best defined if we take a collaborative and a multi-stakeholder approach, which includes patient-reported outcomes, clinical efficacy, cost effectiveness, okay, all measured through standardized metrics and tailored to the respective or specific patient population. That's very important. Okay, and in a nutshell, and if I talk in very simple terms or literal meaning, if all these 3 key stakeholders are happy and without friction, we will get our value-based care. Until then, there is no value-based care. Okay? Please.
Thank you.
That's something.
Dr.
Yeah.
Ariafo?
I agree with Abhishek's I agree with Abhishek's definition. Again, as a pharmacist, to me, value-based care is providing those clinical services that help to drive patient outcomes. Again, as we see now, especially in, when we look at the healthcare landscape now with primary care services with providers, there's a shortage right now, right? Trying to get to hire providers right now is it's a challenge, especially from my FQHC space. And I see pharmacists, again, being able to deliver value in this, especially to help address these shortages. What tasks can we relieve current providers, right? Relieve them from, where the pharmacist can step in and take on this task. Things like medication reconciliation, right? That would free up our providers now to be able to see more patients, right? And do what they do best, right? So to me, that's what I would say, from a pharmacist perspective, is delivering those pharmacy clinical services, preventative care, vaccinations, right? That help to drive patient outcome. Thank you.
Great.
Thank you.
Is there a particular question that you have for me in particular, or?
No, if you want to expand on just the definition so that we're all on the same
Sure.
level playing field with our understanding before we dive into the details.
Absolutely. I think it's important to also understand where we're shifting from, and that's the traditional
Yes.
at the register, collecting the copay,
Correct.
right? Fee-for-service model. And that, I think, I think it's really important to digest that. What does that entail? And it's that volume-based incentivization, for the most part, historically, has shown that it really translates to treatment rather than prevention.
Yep.
So I think that the next 25, 50 years in healthcare is really going to become, it's going to be tremendous to identify preventive strategies to help reduce disease burden, overall prognosis, and then finally cost to our society.
Absolutely.
And I think, what are we moving to? And when we talk about these value-based healthcare delivery systems and models, there might be a fear that, hey, we're not going to be able to collect that copay at the register anymore. But in the end, I think that we're trading that copay fee off with prioritization of several fundamentally important things that I see as a solo clinical practitioner in healthcare, and that's focusing on preventive health strategies, right? I think that we can manage chronic conditions better in a more effective and efficient manner, and we're in utilization of collaborative multidisciplinary resources, which at present, frankly, we don't have time for, nor are we incentivized for.
Yep.
And then finally, I think that I sort of touched on there's a shift in a paradigm and a philosophical change in that patient healthcare provider relationship, and I truly believe that this delivery system or this model of care, value-based proposition that we're discussing here, will be able to shift. We'll actually be able to focus on quality rather than quantity or duration of a person's life.
Exactly. And basically what you're saying, just to add on that, going from a reactive to a proactive approach, that's, I think, that's the whole things of it. We have to do that.
And as the CEO of a public charter school in Florida, when we apply this value-based care paradigm in the school setting, it's very similar to the medical setting, where we are looking at preventative strategies. So we are wanting to implement the therapies early on, the mental health services early on. So it's early intervention prior to us reacting to a trauma or behavior disorder or a diagnosis of a deficit for a student. So looking at how we can intervene early on, whether that's Head Start or VPK programs, all those programs that actually help our students get a head start. And if there is a medical diagnosis, if there's a deficit, if there's a challenge, that we're intervening as soon as we can. So thank you all. I think we now have a good understanding from the different areas of value-based care. So let's move on and let's dig a little deeper. And let's start with some of the challenges that you face in your profession. And let's start with you, Dr. Kumar.
Exactly. I mean, the challenges from a, and again, I'll talk again on the data-driven foundation when, we are talking. So first is the data interoperability. That's the first major challenge. Okay. Data standardization. That's the second major challenge. And the third one is getting the data or data integration from diverse data sources across healthcare system. And I'll try to explain you will be surprised because I was in the thick of that, implementing some solutions for large healthcare systems and large payers. What is the level of data access problems which are available? I would like to definitely share some of my emotional thing there. So again, but these are the three major challenges which are there. And forget about accessing data across healthcare system. Let's talk about one healthcare system. In one healthcare system, there could be, let's say, 20 affiliated hospitals. Forget about those 20 affiliated hospitals also. I talk only about that one hospital in the one healthcare system, three different departments of that hospital. There is a recruitment department. There's a credentialing department, which is called the credentialing verification organization within that hospital, and then there's an enrollment department who is enrolling the providers with the health plans, right? All these departments are taking the same provider data, entering it multiple times into their own system of record, which could be Excel sheet, which could be sometimes the big Excel sheet they call as big Kahuna sheet, okay, or some kind of system. And they are doing it multiple times day in and day out, and none of these systems, none of these departments are talking to each other. So they get the provider information, recruitment team puts all of them pretty much in an Excel sheet or something, and then once they are done, the letter of intent is signed, agreement is signed, all that great stuff, they send an email or something to the CVO, then CVO takes that information, again enters that into some system of record, conducts all the CVO activities and everything, then once they are done, then they go to the payer enrollment department that, okay, you can now start enrolling. Until that time, payer enrollment department has no visibility, pretty much, that they could have started in parallel, okay, for enrolling and preparation for enrolling those providers in the health plans. And now, finally, they again do the same thing, entering the data again to start putting the providers or enrolling the providers into health plan. Now, think about this perspective here. All these the problems, what ultimately it leads to? It leads to the delay in getting the provider participating in a particular health plan. And that means the provider is not seeing the patient, or if they are seeing the patient, there's a high enough chances of their claims getting denied. And ultimately, who's the sufferer? Patient. Okay? So, the value-based care goes for a toss. Okay? So that's the challenge, those three key challenges, and what are the real-world problems which happen. So forget one. I just talked about one healthcare system, one hospital, different department. I didn't even go to other affiliated hospitals and across healthcare system. It's unheard of right now.
Right. So, Dr. Olivero, let me ask you this question. Coming from a pharmacist perspective, when we have weight loss concerns, Ozempic, for example, or tobacco cessation, those type of public concerns, how does value-based care, the paradigm shift, impact those particular health care concerns?
Okay. So, again, when we look at the role of pharmacists in value-based care, I think it's two two main roles. One is the clinical, and the other is that public health advocate. And when you look at things like weight loss, smoking cessation, I think those are public health issues, that pharmacists can intervene in. In terms of value-based care, so right now, when you talk about the challenges from the pharmacist's perspective, number one is the payment. That's a big one, right?
Yep.
Pharmacists right now, in most, depending on your state, are not being compensated for these services. And again, as you said, if we don't rightly align the incentives, then folks are not going to do it. So again, right now, pharmacists are not being incentivized to provide these services, so that's a major issue. Secondly, in terms of, he spoke about the data interoperability. That's a big one too. I work in my current healthcare setting, I work in a FQ, which is a clinic, and our pharmacists are within the clinic. So we do have access to the EMR. Let's look at it from the perspective of an independent pharmacist, right? It's an independent pharmacist in a community, they have patients that they're seeing. How do they, without data interoperability, having this health exchange warehouse where they're connected to, where they can say, hey, provider B or provider Dr. Smith, I see that we have 10 mutual patients, right? And I see that your patients, based on this Medicare star ratings or high-risk measures, they're not meeting these measures, and I've identified these gaps in care. This is the service I can offer, whether it's smoking cessation, whether it's weight loss, and I'm going to work on them. And then having that bi-directional feedback that once he does, the pharmacist has done what they need to do, the healthcare provider is seeing it, and now they're not duplicating that effort again, which is basically what's driving the cost duplication of effort, right? So again, those data challenges. Also, again, for pharmacists, I think some of the things some of the challenges is how do we demonstrate value in this new,
that's a good one.
This new healthcare model. But we can, again, I look at it, the four main challenges is, the data interoperability, bidirectional communication, real-time data, payments,
Yep.
and then demonstrating value. But I say if we can solve the first two, the data interoperability, bidirectional data, real-time data, then it's just a matter of time that you're going to be able to demonstrate value, because now you have data to say, hey, see what I did. I worked with Dr. Smith. I was able to follow 10 patients. I identified these gaps in care. These are the interventions I made. It's documented, and this is the result. I mean, it will only take, payers have to be out of their mind not to want to reimburse you for the value that you have done, that you have created. So I think, again, if we can solve those two, the data aspect of data interoperability, bidirectional data, real-time data, and also, again, another important thing is when you have data, because again, I'm speaking from my perspective as working in a healthcare clinic, we have access to data, but then somebody has to sit down and scrub this data, interpret this data. How do I know who should I be reaching out to first? That risk stratification, and I again, I'm happy we have Abhishek here to say, I believe AI can help us with that. What task in scrubbing that data, making sense of that data, can AI take care of so that the pharmacist is actually spending time in the high level tasks that deliver the value we're looking for, the clinical interventions, the patient counseling, the education, right? So I think that's my perspective. Thank you.
Fantastic.
Awesome.
Thank you for that. So next question, piggybacking on things that I've heard, how does collaboration with other professionals help us to promote value-based care, to prevent the gaps in service, and to ensure that the data interpretation is valuable for the patient?
Yeah, I think before I answer that question, I think it's, the way I see challenges at present, I think from a bird's eye view, I think a major challenge is there are a number of parties that have to essentially, be on the same page. First and foremost, it's our patients, our healthcare providers, They need to be on the same page. Our payers need to be on the same page as our patients and our healthcare providers. And then finally, governing bodies, right? Governing bodies, obviously, local, state, federal governing bodies, professional organizations, like for me in particular, the American College of Cardiology. All these entities have to be on the same page. Mm-hmm. And I think that has been a challenge for, I mean, this is not new, right? This value-based healthcare delivery concept is not new by any means. Right. I think the reason why it hasn't completely taken off is because of this. I think taking a little bit, going into the weeds a little bit, I think that another challenge, I think a major challenge I see is of time. And what I mean by time is there's an upfront investment, whether you're a large healthcare system, whether you're a multi-pronged group, multifaceted, multi-specialty group, or for that matter, you're a solo practitioner like me. And there's a time in creating, tailoring, curating an individualized, personalized plan of care for each and every patient member of yours. So I've got 3,000 patient members in my panel. I want to create a personalized. I want to create a personalized prescription for that patient. Mm-hmm. Mm-hmm. And then obviously cost. And what I see as cost as a solo practitioner is not necessarily, how am I going to, balance my books at the end of the month. The way I see cost is really how do you end up recruiting and hiring highly trained, experienced personnel, healthcare providers that can help. Most importantly, what I see is how do you hire these people that can help you as a provider coordinate care, communicate with your patients. You're bringing up data analysis, how to actually look at that clinical data in a meaningful manner, right? And then finally, engaging with patients. So that's not just money, that's also time.
Exactly, and time is money, of course. So, yeah.
And then I think going to your point, I'm sorry, repeat your question one last time.
Collaboration
and
with professionals to prevent these gaps in care.
Right, and I think it goes to sort of my point about creating a team and all being on the same page. So that whole team has to be on the same page. Reimbursement has to be, essentially thought of as, okay, we're taking care of this patient in a group fashion, and we need to figure out how to reimburse each and every member that is providing care in that comprehensive, multifaceted way.
And Doctor, you also mentioned, put a very good point on, the value-based care, both in terms of primary care and specialty care, that, coming out of that one shoe size fits all strategy and creating a customized treatment plan is the way, is very important, because the medical conditions are getting aggravated by the day. It's not the same medical condition which used to be there like 10 years before, right? There are different kinds of complex medical conditions which are coming, and if I have more medical conditions, I need more care, as simple as that. So even if I have the value-based arrangement, okay, that value-based specialty care arrangement has to be customized for a patient like, in me in this case, to be more personalized as compared to, other patient who does not need that much of care. So that's a very interesting paradigm also, which you just brought.
In line with data and the advent of information and the amount of information we have, that allows us to personalize care.
Correct? Exactly.
That allows us to personalize care in a very, very meaningful way.
Exactly.
So just because you've got a diagnosis of stable coronary heart disease doesn't necessarily mean that you have to take a statin drug, although certainly it's highly recommended. But there might be other lipid-lowering or that may ameliorate your risk for developing complications from known coronary heart disease, perhaps better than a statin drug. And we know, and we can gather that information in a very, 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 very sophisticated, elegant way using proteomics, genomics, and we're able to identify each person's risk profile and what puts them at risk for an acute myocardial infarction, right? What makes him or her higher at risk versus the person that is sitting next to them? And I think that's what makes this so fascinating right now.
I want to go back to the issue of time, right? Because I think that's where pharmacists actually do come in. There was a study that was done by the National Association of Community Drug Stores, and in this study they discovered that patients actually see their pharmacist. They visit their community pharmacist 12 more times than they see their primary care provider. I think that just creates that wonderful opportunity. I mean, if you're coming and I'm seeing you 12 times, I'm not scheduling an appointment, so that accessibility. Imagine having a relationship with a pharmacist. That, let's go back to the patient that has the issue with their heart, right? And you say, hey, they can look in the system and say, hey, Dr. Smith's patient, I know has this issue. They come in 12 times. It's just a quick conversation. Hey, do you have a second, right? I noticed this. Do you have a second? Let's 15 minutes, let's talk, let's counsel. There they can see, oh, I see you're not taking your meds, right? This is the impact. This is the implication. I need you to refill this medication. And by the way, I see that the last time they did your levels, your lipid levels, I can see it there, and this is what that means. A lot of patients go to the doctor. I mean, 15 minutes. How much education can the provider offer the patient in 15 minutes, right? What are your numbers? What do these numbers mean? I think the pharmacist is well placed because we do have that time. They're already in the pharmacy. We're not having to call them. They're already there. And I think we could leverage pharmacists in that aspect.
So how do we do that? So you're actually in a clinic, but what about us that just go through the drive-through and pick up our prescription and we're just passing through?
So that's the 12 I'm talking about. It's for community pharmacists, not in a clinic. In my clinic, I think our patients it's double that, because then they come to see the provider, they pass through the pharmacy, and they actually come to the pharmacy. So we have more higher number of touch points with them because we're right there underneath that same roof with the provider.
Right.
But for the community pharmacist, it's still 12 times more than they see their provider, which I think that's very that's significant, right?
So I'm just imagining going through, and I'm not promoting any pharmaceutical company or company where I pick up my prescriptions from, but I can imagine going through the drive-through and my pharmacist say, hey, can you come in? Do you have time? Instead of coming through the drive-through, can you come in so that I can talk to you about your prescriptions? I see that you're seeing this provider, and provide some patient counseling and some education.
Right.
That would be value-based.
Right.
Exactly.
In real time.
Right, exactly.
Yeah.
Exactly.
So,
and having that AI or that technology
Correct.
that flags that patient, that flags you in the system, that said, hey, by the way, this is needed. These are the gaps. These are the issues that you could address.
Exactly.
Instead of somebody going through Excel sheet and having, by the time you're done with the Excel sheet, the patient's already gone, right? But having that technology that can flag what's needed in real time, so then the pharmacist can then provide that service.
And it's very much there. I mean but I always go with that analogy that we have so much of data, but we don't have data. Okay, that's the problem. Okay, as if you are in that ocean with the water all around, but you cannot drink even a sip of the water, although you are thirsty, right?
They say your data reach. I think it's data reach, information poor. They say, right? Something like that.
Exactly. So all that intelligence that you talked about, okay? Because with all the patient information and everything that we have, the treatment data, the discharge history, the EMR data, EHR data, all the data can be very well consolidated, and a predictive AI model can be written based on that one to say, hey, you have a likelihood of getting a chronic condition in next 6 months to 8 months, and this is the data what it says. And if you are not taking these medication, or in fact, we can do a prescriptive analytics there to suggest the best course of action. Okay, these are the medications you should be doing. These are the fitness related coaching you need to do. These are the all those proactive intervention strategies that can be placed for that patient to not become a patient. And ultimately for the payers also, then I'm saving cost,
Right.
because the cost of hospitalization that would have happened or will happen in next 6 months or 1 year down the lane is 10x more than getting it resolved through primary care. So why not?
Right. And so when I think about what I'm hearing in our conversation, we've been kind of stagnant in this trajectory and moving towards value-based care. If we had an opportunity to talk to the decision makers above us, who actually have the power to just complete the shift, what would you say? How would you advocate for value-based and just patient empowerment? It's open to anyone.
Okay.
I can go first.
Yeah,
I think it starts with policy, honestly. I think policy would help drive, it will help drive that change. When you have the policies, from the policymakers, then make this, that really are aligned. And as you said again, everybody, all the different stakeholders, and policymakers are stakeholders in this too, because again, and once we have the policies, and the policymakers saying, okay, this is where, this is what we want to do, and this is how we're going to do it. Mm-hmm. Then I think payers are going to fall in line, right? As payers fall in line, then it just goes down the chain that way. I think it permanently starts with policy changes that support value-based care.
Yeah, absolutely. I definitely believe that we need to convey to regulatory bodies, our societies that we're affiliated with. They're certainly fighting for us as healthcare providers. We need to ensure that they understand the importance of this model when it comes to the opportunities that not just us as healthcare providers can gain, but the patients. And what I mean by that is, we can truly see empowerment of our patients through this particular model. And what I mean by empowerment is they're going to become more invested in their overall well-being, right? It's going to force them to become more invested. And when I think about being more invested, when I find that when my patients are more invested, what I've seen over time is those patients are the ones that are better at dealing with their chronic medical conditions, or for that matter, are the ones that perhaps avoid developing debilitating chronic medical conditions. Mm-hmm. And then when it comes to healthcare providers, I think it's an opportunity for us, and I think it's important for these regulatory bodies it's important to show them that we have an opportunity to focus more on granular metrics rather than the traditional metrics that we've been taught. So what I mean by granular metrics I'm talking about focusing on the full spectrum of care and the external factors that influence a patient's health trajectory, right? Mm-hmm. Mm-hmm. And I think that when we as healthcare providers are focusing on granular metrics, we're able to better have open dialogues with our patients regarding realistic treatment goals and their overall prognosis.
Makes perfect sense. And I'll try to answer this again from being a data advocate, from the data angle. Okay, first and the foremost, foster a culture of data-driven decision making. Incentivize data sharing techniques, data sharing strategy. Incentivize that, and going over and beyond. And again, that's inevitable. That's also going to come. Data democratization. Why I need my data to be stored or owned by a healthcare institution? Why not my data? Because it's my data. I am the owner of my data. Why not my data can be there in a blockchain, in a shared blockchain, which has stringent security standards that decreases very well the probability of getting it hacked and cheated and all those things. Why not my data can be there in blockchain, and I get a decentralized identifier that is called as DIDs. So when I, now think about a situation here, okay? I go to the provider, I say, provider, my DID is P001, okay, great. So provider, and I am the owner of my data, I can give access, a temporary access to my provider, to that data, where he or she can get all the information that is related to my treatment, vaccinations, blah, 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 everything that has done to me, and then he or she can prescribe whatever the symptoms are, diagnosis is, conditions are, and then update that data, and it updates back that into the blockchain. Again, and it's there with my ID. I go to the next provider, it's already there. Today, how it happens? If I have to go to a doctor, and if I was not going to that doctor, I'm going for the first time, in order for that doctor to get my medical history and everything, they will fax.
Right.
By the way, we are still doing the faxing in this digital era. Okay, they will fax the information to another practice. That another practice will take its own sweet time to give that data in the own snail mail pace. Okay, however, and we in fact we use snail mails also sometimes for that. Okay, and that data reaches. And after that data reaches, what I do as a provider, my staff again enters the data into some of my system of record and everything, which we don't know if the data that was received from that previous entity is still complete or reliable or not, because it could be outdated, it could be, who knows, because of so much of redundancies and everything that has happened. So that's a broken thing. Why I need that data to be controlled anywhere? Why not I become the owner of my data, democratize the data, put that into blockchain and give me the DID, that is a decentralized identifier, there are verified credentials. It is already, there are works which are happening on these blockchain technology, and it is inevitable, it is going to come.
And I think, just to touch on redundancies, I think it's important to reiterate to lawmakers, governing bodies, our societies, that redundancies cost money. And more importantly,
absolutely,
these redundancies, as you're well aware, when you're prescribing when you're helping us prescribe medications and dispense them, redundancies can can lead to morbidity as well as potential patient mortality.
Yes, definitely.
And I think that is what needs to be reiterated. I mean, I'm pretty certain that our governing bodies, lawmakers, payers are well aware of this. But you're absolutely right. My fax machine is running right now at my office.
Exactly, yeah.
So let's talk about if policy doesn't change, if we continue not to be incentivized, and it seems that fee-for-service is going to continue to be the hallmark. How are we going to still have the outcomes that we want and still add value to each of our practices? It's open to anyone.
So again, I can start, again, working for a federally qualified health center right now. Right now, we're, again, for FQs, they get reimbursed using fee-for-service. That's the model, right? Fee-for-service per patient, right? So what we do right now, again, pharmacists are not being reimbursed, but again, because we do see the impact of when pharmacists are embedded in that as part of the healthcare team, and we're helping our clinical providers, helping them to identify those care gaps, and we're working on those to close those care gaps, we see the outcomes. And so right now, we do have our pharmacists. Again, we're not being compensated right now for it, but again, thank God in Maryland, they just actually, again, I know you said if they didn't, but now they have actually passed legislation now that pharmacies are going to be reimbursed for some of the services.
That's good news.
Which is awesome.
Yes.
So again, but I think for us, the good thing is since we've already been doing it, now we have the advantage of just kind of rolling into the model and now, billing for it. But again, we've been doing it, and I think in states that are not getting incentivized, I think we have to look at the greater good. Again, as I was saying, the whole point of healthcare, why we as pharmacists, doctors, nurses go into healthcare is to serve, right? Is to serve.
Exactly,
So,
exactly. And on that, I mean, CMS has already, given that tentative deadline that all the Medicare and most of the Medicaid beneficiaries will move to a value-based care arrangements by 2030. okay, of course, which is going to drive the cost by, with my stats right now, which I read through, it's 8.1% for the Medicare, and it will be 11.1% for the healthcare private insurance companies. So the policy is there. I mean, it's going to change to value-based care, but again, same question goes back to the same thing. Are we still creating the value? Or if we are creating value, what is the cost of creating the value? How we will create value? The question again goes back to the same. And again, we are talking about all these great data analytics tool, AI tool. We also have to be cautioned about, while it brings great opportunities. Okay, AI is bringing great opportunity, but I would also like to highlight there will be downside to it also. I'm not saying that you stop driving the car, as someone was saying in the panel yesterday. You stop driving the car because there were some accidents. Okay. Accidents will happen, failures will happen. It's just about we have to be registering that and making sure we have right policies and procedures in place to mitigate that risk also. Okay, that's the ethical use of AI basically. Okay, so yeah, we can talk more on that one.
And I think again, in lieu of having policies, or again, 2030 is still, that's 20. It's 5 years.
That's 5 years. Yes.
I guess it's going to come in a snap of a time now.
Yeah.
But again, in that time period, is to start working on these things, having the interoperability, the AI, agentic AI. What role can that play in simplifying, making things more efficient, driving more impact? I think we should use that time period to work on these things and make sure those things are ready, so that when 2030 comes, we're ready to move.
To echo your sentiment, that was going to be my exact point. I think we don't have much time left.
Exactly.
You beat me to the punch. I was actually going to tell you that this is a train that's already moving. But you're partly right in that until we do have this healthcare delivery system up and running, as we know, there are a small percentage of commercial payers that are already using this particular healthcare delivery system. Mm-hmm. There are certain states that are better than others. Right. Our federal government is certainly going to get there, probably not soon enough, but but they are going to get there. But I think, echoing your sentiment, we have a tremendous opportunity. We can on-ramp with utilization of tools that your company has expertise in. How do we make, I look at data all the time. It tires me. I get so much data that's completely meaningless. How can we, over the next few years, how can we utilize the science, the resources that we have, to make that information meaningful? So when the vast majority of payers are going to be looking for value-based health health metrics. How will we, how can we make sure that we're going to be put in the best position to succeed?
Absolutely.
And let's talk to our audience about what it looks like moving forward and how they can assist us in pushing forward this paradigm shift.
Absolutely. And and again, most of the people must have every time has the questions about the AI and there will be AI biasing, okay, because again, AI is a model. It's as good as the data that is being fed. Okay, so we all have that question, and I keep hearing that questions every time, from everywhere, that there are problems like that. Yes, there will be problem like that. I'm not denying that. Okay, we have to keep, first of all, we have to have a strict data governance policy, okay, to make sure that we are keeping that in check.
AI governance policy. Yes,
exactly. The second one is algorithmic transparency. Okay, now it's easier said than done, but that is something which is required. How you can create a traceability or transparency in how your model is taking decisions, because they are taking decisions on your behalf. Okay, and you are knowingly or unknowingly going forward with that decision. Okay, pretty much. Okay. You have to ensure that how you are creating that traceability and transparency into your algorithm. Okay, that's the second thing. Okay. So algorithmic this thing. Then conducting regular bias audits, because as I said, the biasing will be there in the data. How you can keep monitoring that keep there has to be a process which is continuously evaluating that, making sure that bias is being identified, and you keep correcting the bias. You cannot reach 100%. There's nothing 100%. The 100% is a myth, but as closer to 100% you can get, that's how good your model is. And then last but not the least, you have to prioritize patient consent and data security, because you are dealing with PHI information here.
Very important.
Yeah,
Yes.
you have to do that. It's HIPAA. HIPAA will kill you for that for sure, and they should kill you. If there is a problem like that. So you have to definitely prioritize patient consent and data security. So yeah.
That's what I was going to say. The way the public can help.
And as you have the mic, we're going to go ahead and do our closing remarks. So whatever closing remarks you have.
All right.
Go
So I was
ahead.
going to say the way the public can help is giving that consent. I know one of the reasons why we in my practice have access is because our patients have given us consent to be able to access their information so we can help them.
Mm-hmm.
So having that consent from the patients, I think it's very important. Yeah.
I just want to end on, I feel, again, humbled and blessed to be part of healthcare during this time. People ask me all the time, why is there so much lability? Why is there so much volatility in healthcare right now? But I think I look at the bright side. And I think some of the discussion that we had here today highlights the bright side.
Absolutely.
And despite the time being volatile, despite it being unclear, I do believe that there's very bright light.
There's light at the end of the tunnel.
Yeah, very nearby. Thank you.
Yep, and I'd like to, again, with my closing remarks, the value-based care is a complex but a necessary undertaking. We have to do it. And by harnessing properly the power of data and analytics, we can create a healthcare delivery system which focuses on quality of care and improves the lives of the patient. That's what really matters. Okay, so. Yep, looking forward for more productive discussions on this as value-based care keeps evolving every day. So thank you so much for this.
And I think as we, the rise of, or the awareness, I should say, of mental health concerns, behavior concerns, I think everyone of us wants and appreciates the value-based care model for treatment, for longevity, preventative concerns. Do we have any questions that we have 2 minutes? Any questions? Yes.
Doesn't seem realistic that the insurance companies are going to change.
Can I?
I'm not confident that. I believe in this value-based care. It's sensible. The way we're doing it now is not right. But I can't see these powerful leaders in this industry doing anything that's going to affect
Their bottom line, right, yes. And I think you all have already mentioned the fact that we have policy changes already that's in place.
Yes.
And so if you want to go ahead and add to that.
I think just really quickly to touch on that, it certainly seems that way. It certainly seems that way. But I think that, I'm certain that healthcare systems, payers for sure, and governing bodies understand that our society is not getting any younger, they're getting older. People are certainly living longer. Chronic medical conditions cost a lot of money. They cost a lot of money. And you don't have to be a genius to understand that preventative medicine, focusing on preventative medicine, will at minimum delay the development of these chronic debilitating medical conditions.
Well, I sort of disconnect because I see you talking, and it's so great because everybody here is 100% into treating the whole person. But the healthcare system, they don't want to do it that way. They're not interested in that at all. So there's a disconnect between, because when you go to the doctor, you're like, oh, well, they don't even care about me, but I know you do. But you're constrained in the way that you can treat people.
What,
So it's
what
very interesting.
what systems and payers do appreciate is money and costs. And right now, healthcare costs a lot of money in this country.
Thank you so much for your time, attention, and engagement. If you need to speak to any of us, we will be glad
Yes.
to answer your questions on the side. So thank you.
Thank you. Thank you so much.
Excellent. Thank you, panelists, for breaking down the challenges and opportunities in the value-based healthcare.